Our next speaker is Dr. Abbass Chamsuddin. He's Associate Professor at Belmont University in Beirut. He's going to talk about management of venous insufficiency.
Basically, what I'm going to do over the next 20 minutes is to go quickly over a review of the endovascular therapy for venous insufficiency. And it's hard really to follow after these two great talks of my predecessors, but I'll try my best actually. I have disclosures to make. And my background here is really a consensus that was reached back in 2010, I think, about the treatment of venous insufficiency, and basically just change a little bit of the nomenclature of the venous anatomy. Basically, the venous anatomy, the veins of the legs are superficial and the deep, and basically those are deep to the muscular compartment, and those are superficial to the muscular compartment. The superficial ones are the ones that are for our interest today. Mahmoud spoke about the deep ones this morning. The superficial ones are innumerable. Basically, all the veins that drain the skin and the underskin and go into the eventually into the deep system are called the superficial ones. And those, of course, include the great and small saphenous veins. Now, in the nomenclature of that consensus I showed earlier, we come to the conclusion that the anatomy actually is supposed to be called as such from now on: superficial veins, deep veins. The great saphenous vein now replaces the greater or the long saphenous vein. The small saphenous vein now replaces the lesser or short saphenous vein. We have the anterior and posterior accessory trunks or accessory greater saphenous veins, the veins of Giacomini and the truncal veins. Now, two important landmarks in the superficial venous system is the saphenofemoral junction. Of course, I'm sure all of those that treat venous insufficiency know exactly what I'm talking about. And then the saphenopopliteal junction in the back of the knee. The great saphenous vein, or like I called it, the mighty saphenous vein, the mighty great saphenous vein, is really the longest vein, the longest straight vein in the body. It starts by the ankle and runs along the medial aspect of the leg and thigh to basically drain into the femoral vein, typically at the level of the groin. The small saphenous vein starts along the lateral malleolus, kind of goes a little lateral and then rather more midline in the back of the leg and dips into the popliteal vein in 2/3 of the cases. Sometimes it's actually a continuous cephalad and finds its way into the posterior side to the deep system. Now, what we used to call the anterolateral trunk is now the anterior accessory greater saphenous vein, and this actually, a lot of those of you who have treated venous insufficiency know what I'm talking about and the importance of these veins. Basically, a lot of time the great saphenous vein itself is normal, but then you see varicosities along the posterior and anterior aspect of the leg, and for that, look for incompetence of these two trunks. The vein of Giacomini, as you know, is the intersaphenous vein. It's really the connection between the small and the great saphenous vein. And this can basically be a cause of recurrence of disease, something we need to be aware of when we treat these venous insufficiencies. Of course, to remember always are the perforators, which are connections between the superficial and the deep venous system, and these contain one-way valves going into the deep venous system. These perforators should not drain superficially. They should drain directly into the deep venous system and can, in themselves, be the result of varicosities in an otherwise typically healthy great or small saphenous veins. So if we look at the venous anatomy of the leg, we have 5 levels of veins going from deep to superficial actually. The deep veins, the superficial veins, the small and great saphenous, the perforators, the reticular veins, which kind of like are in between the sizes of the superficial and the rather small cutaneous veins that we tend to call spider veins. And if you look at it in cross-section, this is actually where the anatomy is, and obviously, if we're talking about the superficial system, anything in these 4 layers can go wrong, and therefore we can have abnormal veins showing up. Now, how do the leg veins work in the arterial system? We don't need to ask. We have gravity, we have the heart, we have the elastic recoil of the arteries, which themselves actually are a pump. In the venous system, basically, the blood has to be pumped upward by the muscles of the leg, which are always working as we stand up, and of course by the unilateral flow of the valves. The problem occurs when the valves stop working and become leaky. Therefore, the otherwise supposedly going up blood tends to leak through these valves, and therefore we end up with a volume of blood remaining in the legs, therefore causing varicosities, which basically are piggly wiggly or higgly wiggly veins that are unsightly and basically give you all the kind of symptoms that a busy venous practice can see. In addition to the cosmetics of it, really are the otherwise list of symptoms you see here. Now, it can become a health issue, of course, if left untreated. The symptoms can get serious, and they can get as worse as the need for amputation, of course. And the other problem that can occur is, of course, superficial thrombophlebitis, basically, and that occurs in somebody that has very tortuous and large veins. These turns in the vein themselves become areas of stagnation and can cause a clot formation and what we tend to call actually superficial thrombophlebitis. You know, pulmonary embolism does occur, although very rare. However, typically the symptoms are more of pain, swelling, induration, and so forth. Now, what are the chronic complications of venous insufficiency? We go from skin discoloration to hemorrhage. When I was at Emory, I saw a patient who lost half her blood while sleeping. As she woke up, she found herself laying in a pool of blood from a ruptured varicose vein. The skin discoloration is very typical, and basically this is hemosiderin that actually tattoos itself in the skin. There's really no way to treat it. Some people claim laser can take care of it, superficial laser and the YAG, but this is a very ugly thing that I tend to explain to the patient, this is not gonna go. If you're coming for this, even after I treat you, this is not gonna go away. This patient actually was being treated with digoxin for heart failure, turns out to have venous insufficiency and has the typical finding of a crown of vein at the medial malleolus, what we tend to call the corona phlebectasia. And of course, the biggest fear is a venous ulcer, which is never going to heal because the problem is there's too much blood in there. There's too much low oxygenated, high CO2 pooling blood. If you don't treat the underlying cause, you're probably going to have a hard time healing this. This is another patient that actually has everything that you can see. Varicose veins, venous ulcer, hemosiderosis, atrophy of fat, everything you can wish for to see in one leg, basically. So absolute indications are those of complication of venous reflux, and of course the cosmetics and appearance of it. This is a slide that I borrowed from Robert Min that shows how we actually test for venous reflux at the saphenofemoral and saphenopopliteal junction. Typically, venous flow has to be unilateral, basically one color on the color flow. However, when you press, and you test it with the Doppler, this is an abnormal venous waveform. Typically, a venous waveform that goes both ways is abnormal. That is indicative of reflux. This is an enlarged vein. Unilateral flow, when you test it, you can see a rather waveform that goes up and down, kind of like a musical instrument, if you want. Current treatment, just a quick review on those. The initial approach was ultrasound-guided sclerotherapy, basically something like the same approach my predecessor just described for venous malformation. However, the failure rate here is extremely very high, and most papers really agree on this. Some people claim to have a better result, but that really remains. I remain skeptical about those. Initial high ligation back in the 70s was very promising. However, a lot of those are coming back nowadays, especially the baby boomers, with a lot of recurrence. Last week, I treated bilateral greater saphenous veins from the high ligation technique. High ligation and stripping for a long time proved to be efficient until we came out with other techniques. Basically here, what we do, we ligate the saphenous vein at the level of the saphenofemoral junction, and the entire leg, the entire vein is actually connected to this long rod and basically cut off and stripped out. SEPS, which is a laparoscopic technique to ligate the perforators is really a technique that's kind of dying out with the new available technique. If you look at the surgical literature, initially, although the results are nice, then you start seeing a lot of incompetence at 5 years. This is a long series by Derryhouse et al. And I can tell you probably at least the theoretical value of this. Why are we seeing a lot of recurrence after high ligation and stripping? Well, the anatomy is not as easy as I pointed to earlier. At the level of the saphenofemoral junction, we have an arboration of veins that will be dissected and ligated when the surgical stripping occurs. Now, the body is not stupid. The body will take these as areas of occlusion, and collaterals will form. And this is a postulation that the high failure rate of the high ligation and stripping really is related to the actual surgical trauma that occurs to the venous system at that level. Now, ambulatory phlebectomy, any busy vein clinic does perform those. This is a way to actually mini-strip small local varicosities, and will probably remain a good technique, although foam sclerotherapy is gaining more popularity. There are a bunch of hooks that we can use for those. We tend to use the regular old grandma's knitting needles, actually. We buy them for $5 a set. I just want to throw in something that came across recently, which is the glue embolization of the saphenous vein. There's a series that was published by Dr. Nick Morrison from Arizona. And basically, it's a catheter that's inserted in the saphenous vein, and a glue under the trade name of Saphion is being injected. I have to tell you, though, the same series itself states at 1 month, okay, at 1 month, 8% of recanalization. 2 of those were completely recanalized. Another complication described is clot extension in the saphenofemoral junction, which I believe is a serious complication. However, that probably was related to the high position of the catheter. Only time will tell us whether this is a good technique or not. Coil embolization of the saphenous vein have been used. A combination of coil and foam has been anecdotally mentioned. I haven't seen any series for that. Correct me if I'm wrong. Now, endovascular ablation really came out as a necessity, a treatment of necessity, because of all the trauma and all the morbidity associated with surgery. And basically, it entitles inserting some kind of a heat element or heat-producing catheter inside the saphenous vein and completely occluded. 2 systems are there. The radiofrequency closure system that initially depended on contact with the vein itself was later modified by Covidian. This actually is a radiofrequency ablation fiber that extends over 10 centimeters, and you can actually do 10 centimeter signals. This is probably the easiest way to use because it auto-regulates itself. All you have to do is just press on this button, and it just will do the job. The largest series, of course, is by Dr. Rosenblatt. I'm just, for the sake of time, I'm going to go a little quicker. Laser ablation, which stands for light amplification for submitted emission of radiation. Laser energy actually only works on tissue that absorbs it. And basically, the idea was to hit the endothelium of the vein with 980 nanometer laser energy, which gets absorbed completely, or at least to the maximum at the time the laser energy at this wavelength was introduced, and has done a great job. However, now, as laser systems got more sophisticated, we're up to 1440 or 1470 water absorption wavelengths. A much lower energy is now produced, therefore less pain, less incapacitation, and a high absorption of laser. The endovenous laser therapy has also been published by Robert Bin, the largest series available. Going quickly over the technique, basically access the vein, and it's the same element basically for RF and laser. This here I'm showing the laser technique. We place a vascular sheath, we place a laser fiber, and connect it to the generator, turn on the generator, and slowly pull back. And here we go. We put a little Steri-Strip, a compression hose. Patient walks for about 30 minutes and goes home. So basically, I hope I gave you a quick overview of the mighty saphenous vein. This is the patient I treated last month. Actually, he's a vegetable, he has a small vegetable shop, so his ability to move is very important. He's got a non-healing ulcer, he's got hemosiderosis, saphenous vein, and this is after 1 month of endovascular ablation and phlebectomy. Now, comparing the two procedures, of course, surgery and endovascular are now probably non-comparable. I think at this time, we have reached the gold standard that surgery is out, endovascular technique is in, and I think endovascular technique has won. Whether you use laser, RFA, or anything else coming in the future, I think there's no comparison to the cost, to the feasibility, and the efficacy of these two comparison. One thing I have to tell you, don't mess with the greater saphenous vein, because if you don't treat it well, it's going to come back and bite you. Treat it as a mighty majesty, basically. And I'm going to conclude right here, and thank you for attending Paris 2014.